Um, and will be our session. And Francis, as you all know, is a professor in our school, has previously been a director of the school, and also has been a CIHR Infoway research chair. And today is going to talk about work in sex and gender in relation to electronic health records. So I will just pass it on to him.
Thank you very much, Andre. I recognize a lot of the names here and faces, so thank you very much for joining. I'm going to actually turn my video off so it's not as distracting, and I'm going to do sharing of the slide deck, if I may. So just bear with me for a moment. Hope you can see my slide deck. So again,
yes, no problem.
Thank you. So thank you everyone for making the time to join me in this seminar on modernizing gender, sex, and sexual orientation information practices in electronic health record systems, or GSSO in EHR for short. So as Andre said, my name is Francis Lau. I'm here at the University of Victoria School of Health Information Science. And I'm one of the researchers on this project that I'm about to present to you. And I'm presenting this work on behalf of our planning project team, Infoway Section Gender Working Group, and contributing members from organizations and communities across Canada. Before we begin, I wish to first acknowledge with respect the Algonquin speaking peoples on whose traditional territories the University of Victoria stands, the Songhees, Esquimalt, and the Wasanich peoples, whose historical relationship with the land continues to this day. And I hope that each of you will join me and acknowledge the privilege we have of coming together in the spirit of respectful dialogue from the traditional territories of the Indigenous peoples from across this land known as Canada. So for today's seminar, our agenda will cover these topics. First, I will explain what are the issues that justified this work. Then I will describe what we did about these issues and what we found. Next, I will go over the highlight of the action plan, that is the output of this work, and close the session by outlining the next steps ahead. So what are the issues? Why is it important that we need to make the effort to modernize GSSO information practices in electronic health records? To provide some context, I want to point out that sexual and gender minorities, or SGM for short, are among the populations that experience the most marginalizing conditions in Canada. I will illustrate with several examples from the literature. First is a comment from a transgender patient, Jane. I go by Jane, but my chart still has my previous name, John, on it, even when I've told the clinic to update it. Then they called out John at the desk and looked at me funny when I answered. Everyone was staring. It was awful. Here's another example. A lesbian patient went to her woman's wellness exam and was handed an after-visit summary with the patient instruction on avoiding sexually transmitted diseases for heterosexual patients. All she could think of was, nothing on this page relates to me. Then here's another one. Rodrigo is a 40-year-old trans man who went to the clinic with pelvic pain and spotting. A biopsy determined that he had cervical cancer. Well, no one told me that I still need routine cervical pap tests. So what we have here are three examples of the inequities faced by sexual and gender minorities. For Jane, it is the stigma and anxiety of being outed and misgendered in public, which in some cases can even lead to denial of services or even physical violence. In the lesbian patient example, it is the lack of inclusive healthcare environments that recognizes diversity and the lack of healthcare staff who have the cultural competency to provide inclusive care for SGM patients. For Rodrigo, it becomes a patient safety issue because the staff lack the knowledge and experience in providing appropriate care for transgender patients. And what we know from the research literature is that sexual and gender minorities have higher rates of premature mortality, chronic diseases, depression, and suicide, and lower rates of preventive care screening and care. They are stigmatized, experience discrimination and even violence in the health system. They often avoid seeking care when they need it because they do not find the health system to be sufficiently safe, accepting, or affirming. So these examples and the research findings resonate with the report from the House of Commons Standing Committee on Health, which was released in June 2019 on the health of LGBTQIA2 communities in Canada. In that report, one of the key takeaway messages that directly relate to our work is that LGBT communities in Canada experience numerous health inequities. Data collection should be improved in order to obtain more complete picture of the health of gender and sexual minorities in Canada. So what did we do about these issues? Well, we received a CIHR planning grant to generate a coalition of organizations and communities to develop an implementation strategy in the form of an action plan to improve the definition, collection, and use of GSSO data in EHR systems for SGM. The planning project had 4 activities. First, we conducted 2 rapid reviews of peer-reviewed and gray literature, respectively, on GSSO and EHRs with respect to the current landscape, emerging issues, and best practices. We conducted an environment scan on how sex and gender are defined and coded in existing EHRs in Canada and standards communities. This was based on an earlier study done by Infoway. In this particular scan, we examined 52 databases and 55 data standards from 12 Canadian entities and 10 health information standards communities. We explored mind mapping and use case scenarios by modeling a set of relevant GSSO concepts and relationships along with a glossary and collating a list of clinical case scenarios and workflows that need to be developed as part of the EHR specifications. And in November 2019, we created a gender and sex working group with the help from Canada Health Infoway. Through this working group, we held 8 virtual presentations by leading practices in GSSO EHRs and had 8 consultation sessions with 50+ participants from organizations and communities across Canada and abroad who are involved with, affected by, or interested in GSSO and EHRs. Well, so what did we find? Because of the limited time, I will only highlight a few of our study findings. First is that in most existing EHRs, there's only one single sex or gender data field with male and female options. So often there's inconsistency in the data fields, names, and value options. For instance, we found administrative sex, administrative gender, and patient gender being all the names refer to the same sex or gender data field. And different value options are often used, such as 1, 2, or F for female. There are also only a limited number of value options available. For instance, many EHRs use male, female, and other for sex. And in some cases, they may include undifferentiated or undetermined as other options. In doing so, this has actually made SGM largely invisible within the EHR systems. And even though Stats Canada or Statistics Canada and the Canadian Institute for Health Information, or CIHR, have recently published expanded sex and gender definitions such as intersex, gender diverse, cisgender, and transgender persons, there's no guidance for health organizations on how to implement these new terms within their existing EHRs. We also identified 5 themes from the literature and consultation on specific issues of and the need for inclusive culturally competent environments with precise GSSO terminology, standardized data collection policies, guidelines for identifying and matching SGM patients with unique care needs, use of anatomical inventories to remove sex and gender assumptions for all patients, and standardized GSSO data to guide care, support secondary use, expand evidence base on SGM health. And also the need for techno-social organizational aspects when implementing GSSOs and EHRs. So what's in the action plan? We spent several months last summer and fall to co-create a high-level action plan with 7 action items and different implementation options, depending on an organization's priorities and readiness and capacity. After several iterations, we could produce a final version of the plan and made it publicly accessible on the Infoway Section Gender website, Section Gender Working Group website. If you visit the website, you will find 3 documents: an action plan infographic, a summary report, and a full report. Keep in mind, these are only working documents since we are continuing to refine the plan with more detail, and this whole area is evolving rapidly. So now let's spend a bit more time going through these 7 action items. Action 1 is to articulate a vision and goal for the action plan. An example then is to envisage a healthcare environment that embraces diversity and inclusion with explicit policies on how to ensure a welcoming environment that respects diversity and inclusion, have culturally competent staff, and an enabling EHR system to reduce barriers, improve access, care, and outcomes for SGM. Action 2 is to engage and partner with organizations and communities to modernize GSSO information practices to meet SGM needs. And since publishing this action plan, we have continued with our working group meetings and are actively expanding our networks of collaborators and supporters across Canada. Action 3 is to establish the GSSO terminology for patient care, health system use, and research. And to support these different types of usages, this means the terminology need to be multi-level, allowing for the capture of detailed GSSO terms that can support direct patient care activities, and at the same time can be aggregated for health system and population level analysis. And we will take a closer look at this action item later on in this particular session. Action 4 is to enable EHRs to collect, use, exchange, and reuse standardized GSSO data. To do so, we would need flexible EHR systems that can be tailored to meet local GSSO documentation and reporting needs. We will take a closer look at this action item as well later in the session. Action 5 is to integrate and tailor GSSO data collection within all organizational structures, policies, practices, use cases, and workflows. This is a huge topic that can take days worth of discussion just on its own. Action 6 is to educate and train healthcare staff to provide culturally competent and safe care, and to educate patients to understand the need of SGM. Action 7 is to establish a central hub to coordinate this action plan over time and continue the national conversation as the next step. We want to emphasize that this action plan focuses on what actions are needed, with details of who, how, and when still to be discussed and established later. In terms of priorities, Action 1 provides the overall vision and goal for this action plan. Action 2 to 4 are foundational activities that provide the basis for all the other activities. Action 5 and 6 are strategic that are dependent on local and regional priorities and readiness. And Action 7 is the immediate next step to move this action item, the action plan forward. And this action plan can also be tailored for different scope coverage, implementation options, and migration stages by health organizations, depending on the overall fit of the plan with regional priorities, organizational and community readiness, and resource availability. And to determine the overall fit, the suggested approach is to conduct an organizational readiness or needs assessment as a form of SWOT analysis. And this assessment can help the organization identify the enablers and barriers present. And based on their findings, an organization can then determine how to proceed. And the action plan also includes many examples of how organizations have implemented GSSO in their EHRs in ways that can reflect local priorities. I will now go into more detail on the GSSO action item 3, GSSO terminology for patient care, health system use, and research. So there are 3 items I want to focus on specifically. One is terminology mind maps and glossary of terms. Then also data elements and value sets, and also in terms of use case scenarios and workflows. This is the mind map for gender. Now, you won't be able to see the detail, but I hope you get the general idea of the concepts involved. During the mind mapping exercise, we discussed many gender-related concepts, including gender identity, gender expression, and gender role. We settled on gender identity and pronouns as the key concepts that need to be captured in the electronic health record, or EHR. You see that there are different subtypes under gender identity, and there are additional subtypes listed under non-binary, man and woman, which we'll discuss shortly. Here's the mind map for sex. You will see that we have sex recorded at birth and 3 inventories, anatomic, hormonal, and surgical inventories. Now, with these inventories, we can now be more accurate in describing a person's body in terms of the organs present, the hormones received, and surgeries a person has had in the past. Note that the concept of inventories does not only apply to SGM patients, since non-SGM patients may also have the same type of changes to their bodies over time, such as mastectomy for breast cancer patients. And the benefit of having inventories is that it removes the assumption that we often make based on just looking at the patient's physical appearance alone. And here's the mind map for sexual orientation. You see that there are actually 4 related concepts: sexual identity, sexual attraction, sexual practice, and sexual partner. The one that has received most of the attention is sexual identity, which includes such terms as bisexual, gay, lesbian, queer, and two-spirit. And here's the example of the glossary for the concepts identified in the mind maps and their definitions. Each one has a reference source, so we know where these definitions came from. And here are the proposed data elements in blue from the mind map. So you recognize gender identity, pronouns, sex assigned at birth, and anatomic inventory, et cetera, et cetera. And here are the proposed value options or value set options in green for the data elements. I should mention there's also a free text write-in option in purple italics in case the desired option is not among the list. And also that for the 3 inventory, they also allow multiple selections. And here is where man, non-binary, and woman subtypes, now shown in blue, are expanded to show their subtype value options in green. And again, with non-binary, multiple selections are allowed. Note that the subtype for sexual orientation are now in blue as well, because they all have their own value sets, which are not shown here. And this is a table, which is part of a spreadsheet that shows the suggested data field that we may wish to collect from our patients at point of encounter, depending on the circumstances or clinical use case scenarios involved. Some of the examples of these scenarios include registration, scheduling, insurance, billing, lab, and imaging. Now, they can also include decision support and population level scenarios that are not shown on here. So this may be a template that an organization can actually use to ask the question of what data do we need for each scenario? How should we identify our patients? How should we address our patients? How should we communicate among healthcare staff and with the patients? How to provide appropriate and safe care based on the information collected, and how to protect one's privacy. And here is a sample workflow process of collecting sexual orientation and gender identity, or SOGI data, as they're commonly referred to in the United States. This example is actually from Fenway Health, which is one of the leading organizations in the United States on transgender health. So we will need to create similar workflow diagrams for all of the different clinical scenarios and workflows that we have described earlier. Now, I will go into more detail about the action item 4, which is to enable EHRs to collect, use, exchange, and reuse standardized GSSO data. That means we need to create technical specifications to define how our EHRs should behave in order to be inclusive. So here are a list of 8 items I want to draw your attention to. First is data fields and terminology, interfaces for inputs and outputs, security and privacy, data quality, decision support rules, IT support, governance, and also implementation options. And last May, we had a presentation by Dr. Alex Kiroglian from Fenway Health on how they collect and use GSSO data in their EHR. So we will go over some of their examples just to show what EHR features may be possible. So here is their registration screen that shows the data fields for preferred name, which is, by the way, now they have changed it to name used, sex and gender identity, and sexual orientation. And here's the modified chart view of the registration screen where the name used and pronoun are prominently displayed. And they have a THP flag to indicate that the patient is actually enrolled in transgender health program. And here is an example of the organ inventory with anatomical parts listed. And for clinical decision support, there are additional recommended data recommended elements listed that would be needed for specific clinical decision rules. For example, decision support for health maintenance, such as pap smear and mammogram, will be more accurate if we know that the patient's sex assigned at birth was female, but is now male with specific sex organs. So what are the next steps? Well, we completed the CIHR planning project in January this year, and we have co-produced a number of knowledge translation outputs or knowledge products, which includes 3 journal papers and the action plan reports. And right now, we're still wrapping up the KT efforts, working with several journals and publishing commentaries, abstracts, blogs, special issue, and presentations. And we have also ramped up doing presentations such as this one today, and doing interviews with new agencies to expand our reach to the target audience. Dr. Karen Courtney from our school has just received a 1-year REACH grant from Michael Smith Foundation for Health Research to further disseminate our study findings that will be starting this month. And she'll be leading the effort to look at sharing the previous findings from the CIHR planning project, develop more KT tools for applying the action plan in different contexts, organizational and community contexts, such as acute care, tertiary care, long-term care facilities in the communities, etc. And also to develop an implementation strategies guidebook. And for the guidebook, we will start working on GSSO terminology, EHR specifications, policies and practice, and implementation settings for specific settings. And these outputs will become chapters within the guidebook. So with respect to terminology and EHR, we still have a lot of work ahead, because for the terminology, different groups have either expanded their GSSO definitions or have begun to revise the terms. So in addition to our environment scan of the existing EHRs last year and the GSSO action plan that we just published in January, HL7 Gender Harmony Project, which was sponsored by HL7 Vocabulary Work Group, has just produced a set of expanded section gender specifications that has just gone through a ballot and was approved in January this year. And Statistics Canada has recently produced a consultation document on gender and sexual diversity statistical metadata standards that is still collecting feedback from the public. The Canadian Institute for Health Information, or CIHR, has published a document on defining stratifiers for measuring health inequities, and also a reference data model toolkit that have expanded sex and gender definitions. And SNOMED International has just started a clinical project group to work on SNOMED CT terms with a focus on clinical care, such as gender affirmation surgery and related health conditions such as gender dysphoria. So we need to take a look at all of these latest developments so that we can analyze, synthesize, reconcile, and harmonize these sources to update our GSSO concepts and glossary, and to create the appropriate data models suitable for implementation, and define the code systems and value sets that will be necessary for the GSSO terminology. And for the EHR, we need to create technical specifications that include the interfaces, the databases, the rules, privacy, data quality, and workflow scenarios. So this actually brings us to the end of this particular session. I kept it, and these are the references, by the way. I kept it short because I would really want this to be a two-way engagement in terms of inviting you to provide feedback, comment, suggestions in terms of how we should move forward. So on that note, I will stop here and invite you guys for a comment.
Thanks, Francis. And I guess we can use your mic or raise your hand, however you want to do. I have one question to begin with. I know everyone will ask about, how about integration with vendor products? Is this pre-SPADES or other things like standards like SNOMED and that? Is this before that, or where are we at?
Well, there are many moving parts. Thanks for that question, Andre, by the way. There are many moving parts. And some of the big vendors, such as Epic and Cerner, they have already sort of really made the effort in terms of moving towards incorporating GSSO, or what they call SOGI in the States. You have to keep in mind, in the States, the situation is a little different because the Office of National Coordinator of Health IT actually has issued, I think the latest one is 2021, just came out, but the last year they had the Interoperable Standards Advisory that actually specify SOGI data that need to be collected, SOGI meaning sexual orientation and gender identity, along with sex assigned at birth. So they actually have pretty straightforward criteria in terms of the actual sort of data elements that need to be present in order for EHR products to be certified. Now, that said, right now it's not mandatory that clinicians collect that information. As for the other vendors, it's a little bit more challenging because especially in Canada, we're following what's in the States. So, and if the vendors such as Epic and Cerner, they have them, then we may be able to use that in Canada. And keeping in mind, their value sets may be different than what we have, because we need to reflect the sort of local culture as well. As for smaller vendors, such as the EMR for, let's say, especially the primary care physician office settings, that's where a lot of work is still needed, because the vendors really are looking for guidance from organizations, because they won't usually initiate these efforts. They will have to sort of wait for the clients to say, yes, we need it. But then the clients at the same time are, faced with many other challenges. What you mentioned also about SNOMED CT, and there's also LOIN and ICD. Everybody's starting to do a little bit of work, such as I mentioned, SNOMED International has started the clinical project group, of which I'm a member of. They just started, this February. So the work is beginning, and this is going to be a multi-year effort that will take a lot of people working collaboratively together. And I didn't even mention about HL7, when in fact they have a crucial part to play because they look after all the data exchange standards. Sorry, that's a long and winded answer to your question, Andre. I hope that answers it, or at least try to.
It sounds like it's early early on, it's beginning phases. Yeah.
It is early days. I mean, some of the leading institutions, let's say Fenway Health, or even for that matter in Alberta, Alberta Health Services is actually ahead of the pack in Canada because they already implemented some of these features in their electronic health record. So province-wide, and then Ontario Rainbow Health, they're also in the process of educating other organizations that are looking to them as leaders to implement in their electronic health record. Other jurisdictions are trying to play catch up. I'll stop there.
Okay, thanks. And we have a question from Rob Zest in the chat box.
Oh, let me take a look.
Yeah.
I have to find my chat box. Oh, here it is.
Yeah.
I have to scroll down to the top.
It's, hi, Francis. Can we go a little more detail about the value set used, and also how can clinicians be made more aware in terms of conducting clinical research?
The value set right now, so if I can, you can still see my screen, right? So if I can just go back a little bit to the value sets. Right now, that is still work in progress because different organizations, groups, and standards communities have started to put out these value sets. For instance, the Office of National Coordinator of Health IT, they actually have a published set of value sets. That is a mixture of HL7 version 3 and FHIR and also SNOMED CT. But you will, if you look there, you will find they're sort of more or less a little bit outdated because the language itself is changing so rapidly in this field. So even the SNOMED terms are outdated already, some of them. And as to the other organizations, they're now just starting to sort of try to reach some agreement in terms of the value sets that are being used. So Stats Canada, for instance, they have some values that you can call them value sets. But you have to keep in mind, it depends on the purpose of use because they're really responsible for looking at population level analysis. So they want to be at a high level. So they would have something like, cisgender, transgender, non-binary, but that would, while that would be sufficient for population level epidemiologic analysis, but that wouldn't be sufficient for very detailed clinical care. So different organizations do have these value sets, and they're still work in progress by many of them, and we need to really try to come together. I think the other aspect is that these value sets, you have to keep in mind, they're going to change over time. So whatever you do, this is where you really need to embrace the terminology idea, whereby these terminologies and value sets, the terms, we need to be able to evolve gracefully over time, so that if you implement it in day one and start using a particular value set, and over time, you would be able to evolve. And by evolving, you're not going to break the system. There's still provenance involved so that you can track it historically. And there's also, and that's the beauty of moving towards something like SNOMED CT with the terminology, where you have description logic and where you have hierarchy, because you can roll up and down depending on the level of detail that you want. I'm not sure if I answered it or not. I'm trying to look at the questions. Andre, do you want me to just keep going down the list, or do you have other people as well? I'll take another one about the privacy consideration. This is an important one because from the literature and also from some of the leading practices, as well as our own consultation sessions, this is a very crucial issue because of the historical mistrust and discrimination and stigma that have come along with the transgender and non-binary communities or sexual and gender minority communities. There's been a lot of distrust and hesitation or reluctance to disclose. And the way that the current environment is structured, I mean, you often would be unveiling all your information at the registration desk. Quite often it's semi-public. So you are quite reluctant in terms of just giving out this very private information. So I think there has to be a lot of built-in mechanism in place, not only to do with the privacy of the data itself, but also in terms of the environment to make sure that it's safe, secure, protecting both the data itself as well as the person who actually disclosed that information. So a lot of work has need to be done. So that's why it's not really just a technical exercise, but one that embraces policy and practice. And the good thing is that as you know, some of the leading organizations have suggested, is that there are already lots of privacy legislations, regulations, policies in place already, even for very sensitive data. So rather than building something totally different, what you want to do is strengthen it, building on it to see what the existing legislation and regulation and policies can really meet the needs of this additional set of criteria, and amend it where necessary. So I hope that would be a sort of a short answer in terms of the privacy aspect. I'm still looking through the.
There's a whole list. Why don't we just go through the list and then grab the mic? So I think first on the list was Rob Haywood. Are you out there and we have the mic? Go ahead.
Oh, I was just contributing that we've really benefited from all of the excellent work that has been described here and have moved to implement it in the provincial clinical information system. We first made sure that we could capture all of the data. And as Francis is pointing out, that is frustrating because the category list and the terminology is so volatile. But nonetheless, you've got to start somewhere. And then we needed to make sure that in all things like label printers, you know, dashboards, all of our task lists and so on, that we were reflecting things like affirmed name and what we call clinical gender. And then most recently, we've been now cycling back and improving all of our text automation tools so that when people generate facilitated documentation text, that it reflects not the vendors, but AHS's implementation of the kinds of directions that have been discussed here. And as anyone on this call can imagine, there is a world of work involved in doing that. Some of these lists, for example, are multi-select, they're not exclusive, and figuring out how you're going to use information when multiple options are offered, and even selection of things like pronouns can be a challenge. So anyone who wants to dig deep into it, would be happy to share our experience.
Thank you, Rob, for sharing that. And like I said, Alberta Health Services, you know, through the work of you folks and Marnie Panay, I mean, you guys are the leaders in Canada, so we're all trying to catch up to you folks. I'm going to move on, and I see. Sorry, Andre, do you want to facilitate?
Simon Menzel. Simon?
Thank you. Hi, Francis. Thanks for this great presentation. I'm actually quite enjoying it. I have an implementation detail to just think about. That some of the fields you have that are full of value options, some of them seem to be on a pretty definite spectrum. And as people want to classify themselves in between two values, we create a new name for something. For example, you've got man on the left, woman on the right. And so if someone's in between or both somehow, then you create one in the middle. That splitting could go on infinitely. And I wonder if any thought has been given to assigning a visual analog scale, like maybe a slider, to assign a non-discrete value between 2 points. It's just a thought that occurred.
Thank you, Simon, for that comment. In fact, there has been some work done. I think it's called the genderbread person that actually, you know, have the visual image of a genderbread instead of gingerbread. It's genderbread, whereby the anatomical organs and some of the additional information are sort of shown, you know, graphically and visually. And I think it's going to take a lot of experimentation to see, because sometimes this is influenced a lot by cultural background and understanding, and also the health literacy issue as well. So I think it will have its place. and especially when it comes to the inventories, the anatomic inventories and surgical inventories, even hormone inventory. That will be quite interesting to see just how they will play out, because now you have all these iPads that patients can point and click themselves. So that would be quite helpful. And I mean that analog scale is a proven tool that actually is already used in practice in a number of areas, such as pain, identifying body parts, etc. So I wouldn't be surprised if there would be some additional work done in that area. But in terms of in the biggest scheme of things, this is way down the list of what needs to be tackled. But it's a good thought. Thank you.
Thank you very much.
And next one was Richard Zealous about privacy.
Richard, I think I went over privacy a little bit. I don't know if you have additional comments you want to raise.
No, thank you, Francis. It's good for now. I know there are lots of things to consider.
Okay, yeah, thank you so much. But it's at the forefront, so it's certainly a very much on the mind of everyone. So thank you.
And then it looks like Aliyah Jamal.
Whether these forms question value sets have been tested with patient. Well, if you're looking at those example forms that I showed you in the presentation, well, they're actually in production use. They're at Fenway Health. And in fact, if you look at the literature and also look at the action plan, because we've included numerous examples of best practices, those are already organizations that are using these forms and screens and reports, etc., in day-to-day practice. But these are leading organizations, even Ontario, Rainbow Health Ontario. They have forms and they have a lot of material that are already there. With respect to value sets, that's a little bit more amorphous, because, like I said, these are changing. And but in Canada, there are some efforts in trying to move forward in that as well. For instance, if you look at Andrew Pinto's work at St. Michael's Hospital, they actually have sex and gender and sexual orientation as part of their social determinants of health questionnaire, part of the suite of 14 questions that they actually administer to all patients. The idea here is try to normalize it, rather than asking only who they think may be sexual and gender minorities, the GSSO questions. They actually standardize it and ask all patients. And this, in fact, is becoming sort of the standard practice, standard of care in terms of eliciting or collecting what they call in the States SOGI data. We're calling it GSSO in Canada. So I don't know whether that answer the question or not. I think Craig has one. Did you want to talk about this in case people didn't read the text?
Sure, thanks, Francis. Yeah, it was kind of a question. I know that we obviously have to start with data collection, because we need data to be able to identify where problems are. And as you pointed out, we often do research on data that's collected. And if we don't have data that properly identifies GSSO people, they're going to be more further marginalized by the evidence we produce from it. But I wondered if you heard or had any comments around, okay, it's good to collect the data, but it has to lead to a change in the process as we do downstream. I know you talked a little bit about this sort of being a socio-technical kind of challenge. And I wonder if you have any thoughts as to, how do we ensure that we're not just collecting data to collect it, and the process that people then receive downstream doesn't actually reflect any change in EDI principles?
Yeah, thanks for that question. It's an excellent one. In fact, I think it's both upstream and downstream that this is going to have a profound effect. And you do want to have it in design and implement it in such a way that will lead to profound impact, hopefully in a positive fashion. So as you can see, this really needs to start with what is it that we really want to achieve, back to the 7 actions, and that you need to have strong engagement with the organizations, and communities that will make sure that they understand the need for this information, because they need to understand why this is needed and how they're going to be able to use that. The nice thing is that I think we're at a time and place where multiple organizations and communities are recognizing that this is absolutely essential if we want to move forward. I mean, as you saw earlier, the House of Commons report on LGBTQ health identify with a list of, I believe, 20-some recommendations in terms of what needs to be done. And they're more than just data collection. So we're really just one of the 20+ recommendations on their list, because we being informaticians, we want to focus on the information. But if you look at the entire list of recommendations, it's everything to do with trying to level the playing field in terms of ensuring that you can actually have health equity in place. So that's a very important piece. And some of these initiatives that are all happening around the same time is that finally there's now federal government has created an LGBT secretariat. And similar to what we're trying to do with the GSSO action plan for EHR, the secretariat is now working on trying to come up with an LGBT action plan for the entire country. Now, mind you, they're dealing it at the federal level. So there still need to be connections made with between the provincial jurisdictions and also right down to the frontline providers. I think providers, many of them, they realize that they need it, because they're actually, even though, literature suggests, the transgender population, for instance, is anywhere between 0.5 to 3 to 4%. But in reality, it's been suggested that that estimate is grossly underestimated, because a lot are hidden. They're not identified, or they don't want to self-disclose because of the danger and the adverse effect that we may see. So I think things are converging, because in fact, if you look at some of the federal government, they actually now on their passport and driver's license, you actually now start to see X as a marker instead of female and male. And again, clinicians at the front line, they need to be connected with that. And I genuinely believe, and from all the studies that we have come across, many of them, they do want to be culturally competent and have the humility to be able to offer appropriate and safe care. But that has to be done in concert with an environment, a healthcare environment that really champion this inclusive environment where everyone is welcome. So again, that's a long answer to your question, but everyone has to play a part, even the public.
Perfect. Thank you.
It looks like Jerry has one about ISO.
The ISO, well, the ISO, for the longest time, they have a set of value sets for the human sex development. But again, their value set is very outdated, male, female, other, being the basic options. There may be one or two others. But this is where I think they're now all trying to move forward. In fact, I wouldn't be surprised if all these other organizations are going to try to work together to try to harmonize them. You may actually know more about this than I do, Jerry.
Well, I did a little looking around, because first of all, let me say this is amazing work. It's tremendously important, and you certainly, I think you've advanced everybody's knowledge today substantially. The complexity is challenging, and I know ISO IAC doesn't step away from that, and they've contributed a lot to our field of health informatics from the standards perspective over the last decade or so. But their gender concepts, I agree, appear to be, the ones that are published anyway, appear to be quite dated. And I guess my question was more, the read between the lines question was, what do you think the process would be, or how long do you think it would take before the work that's being done in Canada and in the United States, among other jurisdictions, would be able to engage with ISO IEC and get something going there? Or is there even any value in that in the short term?
I do believe ISO is already sort of aware of this at a high level, because Canada Health Infoway is a member of the ISO member. So they attend all the ISO meetings. So I think they're keenly aware of what's happening. And I think they're really just an Infoway, update them in terms of the status, especially what's happening in Canada. And I'm sure the other countries do the same thing. So I think like other organizations, such as Summit International, they actually waited a bit to make sure there's enough traction, enough interest from the grassroots level about this particular topic before they weigh into it. And I wouldn't be surprised if ISO would do the same thing in terms of trying to advance it, trying to take advantage of what's out there already and then build on that momentum. Does that help?
Yeah, it does. It's not a surprise, so that's good. I expect, I agree 100%. ISO often builds on pre-existing standards and works to harmonize and integrate standards from multiple sources. So I think it's just a matter of time. Thank you.
Thanks. I'm just reading through the list here. Andre, are you gonna?
Yeah, we have time for a couple more of us from Mel and then Elizabeth, if you have.
Okay. Yes. Mel is asking about the inventories. Do only surgeries or medications related to gender affirmation recorded, or are medications and procedures recorded regardless of purpose? I think this is still remain to be seen, because so far, I think the one that has been most established, at least with the leading organizations, is the anatomical inventory, because clearly knowing which organ part exists or don't exist is tremendously helpful to identify that person. But as to these other ones, I think those hormones and surgeries really just have come up recently and say, oh, well, why don't we have a hormonal inventory? So for instance, TransCare BC, they actually have recommended that. So they need to have the hormone inventory, and also in terms of the regimen and the date and time of the hormone that was given. As to whether that really should only be just for transgender patients, or can it be applicable to all? Well, I think that remains to be seen, because it's more to do with the logistics in terms of how to implement it. Because now you all of a sudden have to consider a bunch of additional rules in terms of how you manage that inventory, because you don't want it to be inaccurate. So it remains to be seen. I don't have the answer. And I think Elizabeth talks about the customizing system for the Canadian context. Yes, so far, a lot of the efforts have been made in the States, and we're in Canada, we're watching closely and learning from our own sort of leading organizations, such as Alberta Health Services, such as Rainbow Health Ontario, because they are the leaders, and they have certainly, especially Alberta Health Services, they have a value set that has gone through several iterations already. So we most likely want to learn from them. At the same time, we also want to learn from Stats Canada and CIHR, because they also have value sets. The trick is that we need to harmonize them, because the Alberta Health Service value sets, maybe for patient care, that need to go into some level of detail, breaking down different types of non-binary gender persons. But then when it gets down to Stats Canada or CIHR, they may just want to roll it all up to non-gender persons. So remains to be seen. Lots to do still. Sorry, I'm trying to read the comments.
Connie and then Don. I don't know if the mic's on.
Connie, you want to just say it out loud what you wrote? I'm having a hard time reading it because my eyesight is not that good, and it's very small print on my computer.
Sure. It's a great presentation. We've been reviewing this topic as we implement our new hospital information system. One of the challenges we do have is providing education for our registration staff, as this is new to them and the registration process. So this is really helpful to support our training.
Yeah, that's an excellent question, because if you look at our action item 6, it's all about educating and training staff to provide culturally competent and safe care, and even educating patients. And the good thing is that there are lots and lots of resources available now. I mean, if you look at Fenway Health, they have all these training guides and all that. And if you look at Transcare BC, if you look at Rainbow Health Ontario, they got online videos and training materials, training guides. So I think we're in a good place in the sense that we got lots and lots of materials. It's a matter of now putting them together in a way that we can actually help advance care in that sense. So thank you for that comment.
And the last one is from Don. Do you have your mic, Don?
I do. Thanks so much, Andre. And thank you, Francis, for bringing the enlightenment onto this very complex topic. So we just finished doing a fairly substantial, and is still underway, review of the standards for healthcare delivery with the Health Standards Organization, which of course provides the standards that Accreditation Canada uses to basically accredit institutions both in Canada and internationally. Have those organizations expressed any interest or thoughts about what impact this has for their standards that have just been revised?
I must admit my ignorance in this particular area in that I haven't really followed closely. I think these days, many organizations, they're already sort of over the top in terms of the long list of things that they need to do. So I genuinely believe that even if they have not touched on that issue, I think it's on their list of things to do. And I certainly hope that, and this is where we really need to engage all these different organizations so that we can move collectively together and collaborate on this in a way that can benefit each other, because it's just too big a pie for one organization to tackle. So if you can actually point us to that direction, because we're still in the process of sort of engaging in organization to try to enlarge the network to continue on with the work.
Okay, I will do that, Francis. And of
Thank
course,
you.
perhaps something appearing in Healthcare Management Forum might be a really valuable platform to do that from.
We already did a blog post to
Oh, great.
Healthcare Management Forum, and hopefully we'll be able to do another paper soon. So thank you for that suggestion.
Okay, thank you.
Okay, thanks. Thanks a lot for a great presentation on pioneering work in this area. I think we're exactly on the hour. Perfect.
Thank you so much.